depth of my finger rather than just prodding, so you can feel the actual space. So you've got first space, second space, third space and fourth space there, and you go right to the edge of the rib and then it goes on there. So that's one, and then two on the edge of the sternum there, and then that's the fifth. Okay, so mid-clavicular, literally you're looking for where the clavicle inserts here to the shoulder point, and you just place it just a bit lower, so just in the middle of there. So it's in the middle of there. They won't shock you, don't worry. Yeah, I'll hold them for you.
Why I'm shaking?
You do when it is like that, though. It's the way it is.
This is 4.
Yep. So I just put the sticker so that this is downwards, so that when you put in all the cables, and I'll show you in a minute, but then they don't get tangled, see? So that's V1.
Oh yeah, 1.
V1.
And 2
2 goes exactly, if you put V2 exactly opposite it, so on the sternum like that, V1, V2, yeah? And now you're going to put V4, which is your mid-clavicular line. Yep, but in the fourth rib space. Yeah? So feel for your ribs, that's it.
Here. Here?
So that's your fourth, sorry, it needs to be in your fifth space, sorry, that's my mistake, fifth space, one down. But in the mid-clavicular, so over here, that's it, yep. That's it. And then V3 goes equidistant between those two on a diagonal plane. So that, remember, the point is the middle of your electrode that you're lining up to. That's it. And then V5 is your anterior axilla, so it's in line with your shoulder. So just there. That's it, yep. And then V6 is your mid-axillary line. So the chopping, that's how I remembered it when I was learning, chopping them in front and back, and it's literally, but it's got to stay on the same plane as that, but right round to the side. That's it.
Okay.
Yeah?
1, 2, 3, 4, 5, 6.
6 chest leads, 4 limb leads, and that makes your 12 lead. Yeah?
6 plus 4 is 12.
12.
10. They make you 10 lead, but that's your 12 lead ECG.
So I guess, okay, sorry.
And split them off. So they're 4, 5 and 6, and this is 1, 2, 3.
So it's ride your green bike first, and then the 6 limb lead.
It doesn't matter which way round you put them on, obviously, because they all need to be on to take the ECG. But yeah, and then you just connect these up. So number 6 round to there. Number 5. These colours will be different for every make of ECG machine, but they should have numbers on them.
Okay.
So things that can affect the ECG when it's not a machine fault can be poor electrode contacts. That's why I say about making sure that there's a pre-wipe and the skin is dry and clean. If you ever get the baseline is swaying, that can sometimes mean that the electrode's just moving on the skin like that, and so it's a poor contact. So if you take that electrode off, dry the skin, clean it up and put it back on, it should be good. And then the other thing that I find a lot when I'm working in Africa is electrical interference. So if you're working from a generator to power your ultrasound machine, for example, sometimes people might need to turn off the generator or just move the ECG away from the electric field so that you don't get the interference. And that will show on the baseline, you get lots of dark oscillations on the baseline and you won't be able to see the ECG clearly. So that's electrical, but swaying is electrode contact. So there'll be 2 limb leads on the end there, and it just makes it easier just to pull them out. So there's 2 limb leads, and then 2 limb leads, and then there's 2 sets of 3 for the chest. That's it.
Your green, black.
Yeah.
Okay. And
That's the first one. and then we'll run a rhythm strip. And you get the rhythm strip at the bottom. So the first thing to look at is to find your P wave. Yeah.
P wave is around here.
That's it, yeah. And what do you think to the P wave? I'll tell you now that Dean's ECG isn't entirely normal. So he was a good one to choose, actually. Meters per millivolt. So 10 small squares is a millivolt, and 25 millimeters per second. So each small square that you see here is worth 0.04 of a second. And 5 squares, the bigger block, so this block here, that's 0.20 of a second, 0.2 of a second, or 200 milliseconds. So your PR interval should be one big square. So if you find his P wave there, and it goes beyond the square, you see, a couple of boxes beyond the square, so he's got a prolonged PR interval, yeah.
So that's a delayed electrical wave across the
AV node, across this bit here. So he has a little bit of a bigger right atrium, then it takes a bit longer to get through there. And then QRS, what do we think to the QRS?
QRS is from here.
Do you think it's broad or normal length or?
No, it's quite short.
Yeah, it's normal. Yeah. So the duration of his QRS is quite normal, but this is quite tall. It's got quite a spiked R wave. It's quite tall. So do you remember we were talking about the Sokolow-Leon criteria, which is for looking at left ventricular hypertrophy, and that was the cutoff for humans was 3.6 millivolts. You see Dean's is here. It's quite high. And that's because he is athletic and he lifts weights, so he's got a bit of remodelling in his heart too, and that has put his Sokolow-Leon up. So he would be, and he has been diagnosed as having an ECG left ventricular hypertrophy. So his heart actually, because I've echoed it, wasn't hypertrophy, but the ECG shows it is. So that's one thing to look at. Then, so you look at, okay, we think, right, we've got P wave that's slightly peaked, so maybe a bit of an enlarged atria. We've got, the QRS is normal, we've got slightly lengthened PR interval, so probably a bit of a first degree heart block. QRS is normal, and then we're going to look at the ST segment. So this is the S wave, and that's the beginning of the T wave. Now, do you remember earlier I said that the T wave needs to be isoelectric here, flat? Do you think that one looks flat?
Elevation.
It's going up, yeah. So if you were to do this ECG on somebody who told you they had chest pain, ST there, ST there, ST there, you'd start worrying that they've got having a big anterior heart attack. But with Dean, this is because of his training. So that's how it's changed. And here, 5 and 6, he's got it too.
But normally for people, if not doing athletic or something,
this would be flat. Yeah, it would be flat. Yeah, absolutely.
How with the orangutan? Because the orangutan activity is quite.
So that's probably partly why their ECG looks a bit weird and wonderful, which we do need to, and as I say, we've got 30, and some of them look, and it is this segment that looks different, the ST T-wave segment. So that's a good point. It could be because of remodelling, athletic remodelling, as it were, for them, because they're climbing all the time. So, yeah, that's abnormal in a human. Now, in chimpanzees, we do see they have a high takeoff. That's what we call a high takeoff there from the S wave. And that's normal because when we looked at 110 chimpanzees, 90% of those chimpanzees had that. So it must be normal for them. And then we see the T wave is fairly normal. Could be, it's quite low amplitude though. So in a normal QRS, you'd expect your T wave to be somewhere up here. So his is quite low. That's probably to do with the fact that this is artificially high, really, rather than the T wave being artificially low, if you know what I mean. So, yeah. So Dean does have some athletic or right heart athletic remodelling. So his right ventricle is a little bit big, which is reflected in his inversion here. And again, he's strength trained, so that's why he's got the ST elevation. So his ECG isn't completely normal, so that's why partly why I chose him as well, because then we could talk through some of the intervals. So straight away, when you get an ECG put in front of you, you're like, right, I'll look at the heart rate. So the heart rate's 56. I can teach you how to measure heart rate manually. We can do that, but you've got a 56 heart rate. Okay, fine. So I know the heart rate's that. Then just quickly eyeball the R waves. Okay, they look regular. You can do something like this, where you line them up. 1, 2, 3, and then just line them up like that.
Similar or no?
Yeah, a little bit out. So he's not completely in rhythm, but that's not major. If they were much bigger differences, then you'd have a problem. So, okay, so we've got 56, so that's bradycardic because it's below 60. Right, then P wave. Okay, we've got a P wave, so we know we're in what's called sinus rhythm because it's coming from the sinoatrial node. Do you remember the sino up here? So it's sinus. We've got the block through here, so there's PR interval's a bit long, block through here, and then we've got the QRS quite tall, which probably makes you think that the ventricle's a bit thickened because of the high velocity, the high millivolts, sorry. And then we've got some of the T-wave changes. So you're thinking, we've got first degree heart block, so first degree heart block, ST changes, and abnormal T-wave. So in a human, we know we take the clinical background, so we know he's an athlete, lifts weights, that all can sort of make sense. If it was somebody who comes to you with chest pain, then it makes you think something else. And so having the eye in your mind what the orangutan has, if they've got any clinical signs.
The history and what you see in the animal is so important.
Then it can change what you're thinking. Okay. And this is the method I prefer. I count the number of small squares between what's called the R interval, because it's R wave to R wave. So you count the number of small squares, and you do 1,500 divide the number of small squares. So 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 21, 22, 23, 24, 27.
Okay.
Let's do that on here, and then that tell you.
Oh yeah, that's right.
Does it work? 55. There you are. So that's a quick way of doing it. If it doesn't.
So I didn't see the whole time.
Oh yeah. Yeah,
So
it's easy to mark
between
from
here
the R
to
wave.
be here.
That's it. Yep.
Yay! Okay.
So that's just a way of, sometimes you can change the paper speed to 50 millimetres per second, because then it lengthens all the intervals out so you can see what's happening. Because if you've got a tachycardia, you want to see if there's a P wave, if it's sinus. If it's from the ventricle, then you're in trouble because it could be VT. So you'd change the paper speed to 50. I don't know off the top of my head then what that makes all of the, must just double them, mustn't it? But I would just need to check that. But 9 times out of 10 you'll do your ECG on 10 millivolts, millimetres per
So we
millivolt
should
per
check
hundred.
the setting from the machine, or?
Yeah, you can change it on the machine if you need to, yeah. But if somebody brings you an ECG and puts it in front of you, the first thing to check is that, and then you go, right, heart rate, so I'd measure those, so I've got sinus brady, or I've got bradycardia, tachycardia, or then look for the P wave. Okay, that's sinus, so we're in a normalish rhythm. then look at the PR interval and just see. Now, obviously, in orangutans, we don't know what a normal PR interval is and what all the intervals are, but you can look at them relative to each other and think, hang on, you know, is that quite long, or does that P wave look funny? Because, you know, they should have rounded P waves and QRS like that. So that's the way to,
Yeah.
So chuffed, look at that.
It's perfect. It's perfect. Well done. Well done. I'm probably more like the adult orangutans that you'll be doing. So it's
And Aimee might be like the new referral orangutan.
she would indeed.
The malnutrition.
Yes.
Thanks. I'll take that as a compliment.
So you got the 4-chamber view
This is for
pretty much
chamber.
immediately. Yeah.
This is
So you just need to open those atria out. So
Is it for chambers?
that's it. Yeah.
Is it 2 chambers?
Nearly.
Wait.
What you're doing, you're going back to the 4-chamber view and then starting again,
Yes,
and then
it's brilliant.
yeah.
Yeah, that's exactly what you need to do. So you get your septums vertical and make sure that your atria are all open, which is a slight tilt down if you need to open the atria. That's it. And then you rotate round from there. So if you need to open your atria, it's just a slight tilt like that. Yeah.
Oh yeah, this is 2
That's
chambers.
my right ventricle, so you need, no, that's right ventricle, so you need to keep going round, keep rotating, that's it, keep going, keep going, keep going,
Almost
that's it.
there.
And then that slicing movement, it's hard to do on yourself. Yeah. So that's the ventricle, but you're kind of closing it off a bit now, so you need to, that's it, like that. Sorry, that's slipping on my rib.
Oh, that's it.
That's it. So that's 2.
This is 2. It's different angle with when
With
I'm
me,
doing with
yeah,
Steve.
absolutely, yeah. And every orangutan will be different too. So it's knowing that it'll be around there, but it's knowing that when you tilt the probe down slightly, that the atria will
Is it
open.
2?
Yeah,
Okay.
that's 2, yeah, and then further round is 3.
Little movements.
Yeah, absolutely.
This is a 3. That's right? No?
No, I don't know what that is actually, sorry. No, you're on a... You're on
Okay.
no, you are 3, but you've tilted, so you've opened the right heart. There you are, that's 3. Oh, I just had an ectopic.
Exciting. Can you do it again? Sorry.
I don't know how to do it again, sorry. But, yeah, so that's it, stop there. Because if you keep tilting, you open up the right ventricle on here.
Oh,
Yeah?
okay. Okay, start again. It's a 4 chambers. Not really good.
That's it.
Yeah. And then
Keep going. That's it.
It's
2.
a 2.
Yeah.
Open that 3 a little bit.
Yeah,
Yeah.
that's it.
2 chambers, and then now moving slowly to get 3 chambers.
That's it.
Is it
Stop.
3 chambers?
So what I was doing there, Yenny, is I'd zoomed in on your hand and the probe, and then was going between the screen and where your hand is positioned, so you
Yeah.
can get an idea of.
So this is on the same position, but just
Tiny movements. Yeah. Do you want to try parasternal on me?
yeah.
For the young? In here somewhere. That's fine. Where's the cursor? That way. That's it. To that side. That's it. That's it. I might need to tilt more actually. And then come over to the side of my chest here somewhere.
Oh yeah, found it.
That's it.
But it's a little bit difficult because there's some bone there.
You mean the brow's on the way?
Oh yeah, this. Okay, this virus. And when I'm moving, the cursor will be high or.
Oh no, that's fine. Where did it go? Where's it gone?
Here. This.
And then we've got tricuspid in there a bit. What's going on here? Sorry, where's the picture? Here it is.
Yeah.
Doesn't look right. Why is it not doing what I want it to do? That's better. That's it. There. Yeah, and then short is from there round to there like that. Yeah, my parasternals have got a lot harder because I must have lost more weight on the chest there. I'll tilt for you. There you go. Should be easier now. That's it.
Looking good. Yeah. Yeah. Oh.
How with the short paracetamol?
It's hard for me to do it and tilt back, that's all. What I should do is plug it into the screen so I can watch it. In all honesty, most orangutans you won't be able to get these in anyway.
Yeah, because of the
It's the eighth core that you
sex,
want
yeah.
to practice.
Oh, yes. I mean, I still didn't know how to make a sharp paracetamol.
So that's chips. And it's important that you put them on their side like this and put their arm up as well.
She got it straight away, again.
Much clearer when I'm further over though.
So it might be better orangutan on the recumbency.
Right on their
position?
side, yeah. If you can, yeah,
Yeah.
you can try them in both. I find
This is the chambers.
Yep. There you go. Yeah.
I find with big gorillas that I get better images when they're on their back, because as soon as you roll really big apes, it all seems to crush onto each other and you can't get the probe in very well. Like the right side of the chest crushes onto the left side and you can't get the probe in.
There you go.
3 chambers.
Well done. Yeah.
Okay. But our machine is when I want to recording, I should take a freeze first and then record.
Well, you'll need to take 2D images so that it's moving.
Oh.
We'll have to have a look at the manual and see what it says.
Could you just say it again? So cursor again to where the...
Cursor's towards, away from you. Change, yeah, that's it. And then, so that's your apical 4, that view there. And then to get the vein that goes in, you just rotate the cursor so it's facing the head. So the cursor's now here. And then that gives you your main, you see the main tube coming out there? That's the inferior vena cava. And in humans, this is how you assess it with the breathing. So you ask people to sniff, and it gets smaller. So when the orangutan's breathing, you'll be able to see it just getting smaller, and that'll tell you, and that'll tell you that their right heart pressure's normal or within normal range, So cursor that way, sorry. That's right, that's it, you got it. That's my, Still big again. It really I came off a long haul flight and it really dilated and had like little clots in it.
Interesting, because well, more than interesting, but it's sort of like maybe everyone should have just a quick ultrasound after they come off a long haul flight. Just
Yeah?
Yep.
You have to tell me what happened.
So you're a bit round there now, the heart's a bit round, so you need to come down there, yeah? So if you hold that image and then press the colour, that's it, and put the colour on, that's it, on the mitral valve, yeah? That's it. So you can take those. Did you see there how when you did that slight tilt, look, that opens the aortic valve?
Yeah.
You could do that on the orangutans as well, that would be great. So because your machine's only got continuous wave Doppler, what you could do is then push the cursor and push the continuous wave, and it will give you that measurement there. So we could use that as having a look at heart function with that one. And then again, you can put the continuous wave through the aortic valve. That gives us an idea of how much blood's going out every time the heart beats. And you can also, on the tricuspid valve here, can use the continuous wave. So if you close that up, that's it. You can use that to measure right heart pressure as well. So they're the ones you can use there. And then do you remember the tissue velocity that I said about?
Yeah.
So your machine, it doesn't have tissue velocity, it has TDI, that's right. So you put what your machine will then show you is rather than these red and blue, you'll just get this cursor and you'll press a TDI button, which will give you this.
Oh, okay.
Yeah, so you'll just get this, you won't get the colours. And if you can do that from that mitral annulus, as we talked about yesterday, so if you do it there, and then in the lateral wall, if you measure those two, just like that, and then just make sure your baselines, make sure all of these are not being chopped off, and just store it like that, and store that picture, then we can measure things from those. If you could do those, as well as the 2 and 3, that will give us lots of information about how the orangutan's heart's looking. It's incredible. Never seen anybody pick it up so quick. So,
and it's not just a fluke, because she's now done it on 3 people.
yeah, she has, yeah. And just keeps redoing it.
Thank you.
So,
Fantastic. No, you're welcome. Very welcome.